Well, good evening, America, and a very happy Tuesday to you. And guess what time it is? It's 5 o'clock on the Gulf Coast, which means 6 o'clock on the East, four in the mountains, and three in the West. And it is time for Fertility with Fink. I am Fink. You are my friends. We used to call the show Fink and Friends, so we can say that again. I am Fink and you are friends. And it's great to see everybody here this evening, as we do every Tuesday night, to talk about women's health, to talk about fertility, to talk about making a family, and all those things that are important to us. So happy to see all of you here. It is my favorite time of the week, that time when we get to sit down and really just kind of be together and talk about sort of what's important here. So let's say hello to what we've got going on. We've got my Instagram feed here, which is Randy Fink MD. We've got New Life Fertility's Instagram right here. We've got also Facebook, LinkedIn, and YouTube over here as well. So feel free to throw your questions out here tonight. But let's say hello to our friends. Hi, Sheila. Mama Fran, nice to see you. Hello, Amber in Gulf Shores. Nice to see you. You've got a big week coming up. Next week is actually your big week. Melissa, nice to see you here as well. As always, hi, Marlena B. Thank you for being here. Purple Butterflies, I like the name. Victoria Lynn, good evening. And Marie Michelle, howdy. And hey to Jazzy Poo. Kelsers, howdy there. Vic S. Cree, I believe that says. Who else we have? We've got Megan. Thanks for being here, Megan. And gosh, it's nice to see these folks, and folks kind of start piling in after a little bit. By the way, I wanted just to throw a quick little plug into the 5:30 Fuzzies with Fink, the Fink Fuzzies at 5:30. So at half past the hour here, we do a thing where we get together and everybody gets their names called out if I could get to them. And it's the chance for us all to kind of get together. We would hold hands or put our arms around each other if we could, and really send out the positive vibes to the universe, because all of us who are going through fertility treatment or hard times one way or the other, it's the chance for us all to stand together as a community and send out all that good stuff together. And to be honest with you, I think it makes a difference. I always say I don't really feel like there is enough, there's just not enough niceness in the world. There's not enough, being good to other people. So anything that we can do to help out in that regard, I think adds to our universe. It only makes the planet a better place for us to be. Let's see. I have not seen the Bama Gal, my mother and father, just yet, but I'm sure they will be on here, because last week he gave me all kinds of hell because my hair looked ridiculous, and it may still look ridiculous because we're in IVF retrievals this week. So our days are spent in the operating room retrieving eggs here. And so I've been wearing a hat all day, and that is my excuse for having a bad hair day. But my father said, clearly you need a haircut. And yes, okay, I admit it. We're all entitled to bad hair days, or maybe even bad hair weeks, sometimes even bad hair months. And so as soon as I can, hopefully this week, I'll be able to get a haircut before Thanksgiving. Gosh, is your Thanksgiving? Thanksgiving is coming right up. We'll have one more visit together next week before Thanksgiving comes around. But hope you have some very special plans with friends or family to give thanks for all those things that are important in our lives, the things that we often overlook, because it's real easy to get caught up in the weeds and not really be mindfully appreciative of all the good things that we actually have in our lives. And I don't want to proselytize there, but, stop and smell the flowers. It's not such a bad thing. All right, let's jump into some questions here. Hi to you, Marie. Victoria asks, thoughts on a day 6 4CB embryo? Well, so that would be considered what would be considered a poorly graded embryo, but that does not mean that it's not going to give you a baby. So if it is good enough to freeze, which means it is all together in one piece, then it is good enough to create a baby. That whole embryo grading thing is really just a beauty contest. And people get very caught up in the grading of their embryos because as I always say, we've all gone to school, right? We've gone to high school, and we know that when we get some grade in our class, it tells us where we are relative to the other people in the class. And so we look for embryo grading to kind of be the same thing, that it must say how good this embryo is relative to another. Well, the truth of the matter there is that's not what embryo grading really does. It was designed to try to say, well, if you've got a prettier or a higher graded embryo, is it more likely to be a chromosomally normal embryo? And the answer to that is no. I cannot tell you the number of beautiful babies that I have held in my arms that came from embryos that were graded poorly. So, Victoria, my suggestion is don't get too caught up in that. So we do know that a day 5 embryo typically performs better than a day 6 embryo by a little bit. And certainly a day 5 and 6 embryo perform better than day 7 embryos, so much so that some clinics will not even transfer. They don't continue to save blasts beyond day 6. But many places do. And there's no problem with that because there are plenty of day 7 embryos who end up, giving people babies. So it's day 6 rather than day 5. That means that, there's one little strike against it. And the fact that it's a poorly graded embryo statistically means that, well, all right, it may not do as well as a highly graded embryo, if you believe that. But the answer very clearly is if it was good enough to freeze, it was good enough. It is good enough to give you a baby. So please don't think that that's a throwaway embryo. It certainly is not. I would 100% transfer that embryo, and our fingers are crossed there, my friend. Absolutely. Purple Butterfly says, do you always recommend assisted hatching for transfers? I'm scared of losing embryos. So assisted hatching is the process, just like you think of a chicken egg, where the shell, if you broke it a little bit, it helps the little baby chick kind of come out of its shell. Well, assisted hatching is the process whereby a little nick is made in the membrane of the embryo so that it can start to hatch. And a hatching embryo becomes basically can go from a stage 4 embryo is unhatched, and a grade 5 embryo is a hatching embryo. So it upscores the embryo, if you believe in that embryo grading. But there is relatively little risk associated with embryo hatching or with assisted hatching. It's just literally a little nick that gets made in the membrane to help it sort of start to come out. And Purple Butterfly says, I'm scared of losing embryos. And I certainly understand that because there's all kinds of mystery, that goes along with what are they doing with my embryos there in the laboratory? And I get that. But I will tell you, the risk associated with assisted hatching is very, very, very low. So I think you can feel confident in that. Vic says, hello, Daisy in Miami. Nice to see you this evening. Indepino Journey, hello, DH7535. Marie Michelle says, how long do you stay suppressed after 2 to 3 months of suppression? I'm 36 years old. I have stage 4 endometriosis. I had an excision done in June. So basically what happens is that when you're on the medication for suppression, so either Lupron or Orilissa or Myfembree, what's happening is that you are turning off the sort of food supply, if you will, to the endometriosis while you are on the medication. So when you come off that medication, the suppression ends. So how long do you stay suppressed? Well, we recommend 60 days of suppression before doing an embryo transfer. But really, once you stop that suppression, the suppression is over with. The real question is, well, how long does that suppression actually last? So how much time does that buy you? And nobody really has a great answer to that question because we don't, really completely know. But in my mind, I think of 2 months of suppression buys you about 6 months, give or take, of suppression of the BCL6 marker, which is the marker of endometriosis that we can test for in the endometrium. So I think, people often say, well, I did some suppression and I did an embryo transfer, and unfortunately it didn't work. Do I need to do suppression again before I do another transfer? And the answer is no. The suppression that you did initially should be enough to last you, I'm saying, for probably about 6 months or so. Let's see what else we have. Hi, T. Storza. Thank you for being here this evening, as well as a few friends who are here on Facebook, and a couple here on YouTube, and at least 2 on LinkedIn. Thanks for being here this evening. Let's see. Hey to Midgie. Nice to see you. Janine is with us tonight, as is Lexi. Daisy is saying my dad is funny for making fun of my hair. I don't think it's funny, Daisy. Maybe you do. Hey, let's talk about something in the menopause, since that topic came up in our emails, and that was, in someone who is using hormone replacement therapy in the menopause, must one do progesterone on a daily basis? Or even on a monthly basis? And the answer is not necessarily. So hormone therapy, as you know, for many, many years got a very bad rap. And now we are asking folks to reconsider, because the data, is pretty clear that hormone therapy can extend your life when used properly, and also really add something to your life in terms of just more and more years of feeling better, protection on your bones, better libido, better skin, better hair, so a cardiovascular protection. But the issue is that when you get estrogen, you can't be on estrogen alone. That's something that we call unopposed estrogen. So if you have a uterus, you have to at some point get some progesterone to balance out those hormones, right? Think of it this way. Estrogen tilts the scales all the way one way. You need to balance that out by getting some progesterone. Estrogen, as we know from those of you going through fertility, makes the lining of the uterus grow. Well, if that lining grows and grows and grows unopposed, meaning to say there's no progesterone to balance it out, eventually that can cause a precancer of the uterus, and ultimately potentially even uterine cancer. So that's why we give you progesterone. It's really to balance out the effect of the estrogen on the endometrium, on the lining of the uterus. But there are different recipes. There are different ways that folks can take that progesterone. So classically, you can take it every single day with what's known as oral micronized progesterone. That's a natural form of progesterone. You take at night when you go to bed, because natural progesterone has a sedative effect. It makes you sleepy. So that's a good thing. That also helps with some of the sleep issues associated with menopause. But there are some people who just don't stop bleeding as a result of, for some reason, an imbalance between their estrogen and their progesterone. So bleeding after the menopause when you're on hormonal therapy is something that is undesired. So the ideal thing is you take it every single day. But if you keep bleeding through it, then we can switch that up, and we can say, well, we can give you a predictable monthly period. And that's where you take that progesterone, call it, let's say, 10 days out of the month. Or you can use it once every 2 to 3 months, or sometimes even 4 months, just to balance things out. And with a potent enough progesterone, that's enough to balance out that estrogen, and it's a safe thing to do. And Daisy, I know that was an issue for you before, so hopefully that solves the problem there. Hi to Kowser, and oh, there, look, Bama Gal has joined, and so you missed it. We were talking about how my father made fun of my hair last week, but I've been wearing a hat all day, so that's my excuse. So let me ask you this: what's yours, bucko? All right, there we go. Angela Sack, hello, my friend. Nice to see you. Shadia, howdy. And Marie asked, how does insulin resistance affect embryo quantity? My doc put me on metformin without knowing. I'm not diabetic. Would you recommend tracking glucose with a monitor? She says, oh, no, I didn't mean quantity. I meant quality. So insulin resistance is one sort of leg on a stool, on a three-pronged stool. And that stool is kind of, if we think of it classically, as polycystic ovarian syndrome. Polycystic ovarian syndrome is an issue where you've got a lot of eggs that are hanging out in the ovary, and sometimes they are released in a timely fashion, and sometimes they are not. Some people with polycystic ovaries have a regular period, while other people may go through months at a time without having a period, or just completely irregular and unpredictable. So when those eggs are hanging out all together in the ovary, they start to bicker with one another. They fight. They literally fight with one another. And as a result, in normal circumstances, they fight, and one of them emerges as what's called the dominant egg, and it's the one that gets released. That's the one that gets ovulated. But in other scenarios, those eggs will hang out, and literally they fight with each other. And as a result, that decreases things like egg quality. When they're all there fighting with each other, then biochemically, what happens is that some of that DNA can become less stable and can eventually result in a problem with that egg, such that one, it may not get released at the right time, or two, just the quality of the egg itself becomes diminished. So that's kind of what's happening at the level of the ovary. But the other two prongs on that stool are, one, the way the body processes testosterone, and two, the insulin resistance. So we didn't ask so much about the testosterone part here, but that testosterone part, that's the reason why many women with polycystic ovarian syndrome have issues with things like hair growth in places that you don't want it, right? Or hair loss in places where you do want it, or things like acne and an increased risk for gestational diabetes and that sort of thing. But it's the testosterone that causes the hair growth and the skin and the male pattern baldness. But the other prong on the stool there is the insulin resistance, right? And so insulin resistance means that it requires more and more of our body's insulin in order to keep our blood sugar in a normal range. And the way I like to look at it is this. I've shown you this before, so if you're bored with it, I apologize. But our body likes to keep our blood sugar kind of between here and here. And so we're running along somewhere like this, right? Well, then you go and you drink a Coca-Cola. You go and you drink this. What happens? Your blood sugar goes way up here. And so you make insulin that's going to try to take that blood sugar and bring it back down into the range where we know it's supposed to be, right? Somewhere along in here. If you make enough, so insulin resistance is where we make more and more and more insulin required in order to get that blood sugar back down in this range. Diabetes itself happens when you can't make enough insulin, and so the blood sugar itself becomes up here or up here or up here because you can't physically make enough insulin. So to answer your question there, Marie, if you get on metformin helps both with the testosterone part, and it treats the insulin resistance part. So by treating the other two legs on that stool, you are affecting the third one, which is that of egg quality. So think of it that way. You stabilize the stool, two of those legs get stronger, which means the third is just inherently better. And that's the third that is associated with egg quality. Great question there. Appreciate you asking. My friend Amber says, how long after IVF or after a positive pregnancy test will I be seen at my clinic versus transferring to an OBGYN? And will I get early ultrasounds at my IVF clinic? So the answer to that is yes, yes, you will. So here's typically the way it happens. We do an embryo transfer. Usually for us, about 10 days later, you do a blood pregnancy test. And I always tell people, please do the blood pregnancy test. Don't keep doing a urine pregnancy test because it has a very high probability of early on giving you a false negative. And then your heart breaks and you think it didn't work. And all that heartbreak is associated with things in your cortisol levels, your stress hormone, and that's just not good for you because you may in fact be pregnant. So wait for your 10 days and do your blood test, and that's your beta HCG. So once we get a positive beta, then we want to repeat that usually in about 48 hours. And what we know is that about 67%, 2/3 of normal pregnancies, that beta HCG will double in 48 hours. And so that's what we're looking for because that's a reassuring sign. If it doesn't double, usually we repeat it again because sometimes just in the beginning, it's a little slow to get going. Or even one more after that might be slow to get going because again, that doubling thing happens in 2/3 of normal pregnancies, which means in 1/3 of normal pregnancies, it may just not be doing what you expect for it to do. So we watch that number double. So at that point, you're going to be about 4 weeks or so pregnant. Well, so then what we do is we wait until you are about 6 weeks pregnant. And by the time you are 6 weeks pregnant, we should be able to definitively see that pregnancy in your uterus, and we ought to be able to see the heartbeat. When we look and we see a heartbeat, we know that 95% of those pregnancies continue on without having any problems. So that is the happiest news we can hope for. If the beta is not doubling appropriately, then, by the time the number reaches about 1,500, we should definitively be able to diagnose that pregnancy is inside your uterus. Because the other thing that we always worry about is a pregnancy that might be in the fallopian tube, an ectopic pregnancy. And so we find those things very, very early because we're following those blood levels from really the time they're barely even positive. So typically we do that first ultrasound between 6 and 7 weeks. Usually we have you back maybe one more time about 10 days later to look again, just so that we can see that little heartbeat going and see that the pregnancy is growing appropriately. And then we typically refer you to your OB. Now, things can be difficult in getting OB appointments these days. There are some practices that will not even see you until you're 12 weeks of pregnancy. When I practiced OB, I wanted to get people in absolutely as early as I could, but different practices do things differently. So it may sometimes be a little harder to get into your OB practice. So certainly if you have a relationship with a practice, that is a good way to go because then, they may be more apt to see you earlier. If you are establishing care at the time of pregnancy with a new practice, sometimes it's a little harder to get in. But typically by 7 to 8 weeks, we have referred you out to your OB because the IVF practices, we don't practice obstetrics. And so we want you to get plugged in with an OB. But yep, you'll get a couple of ultrasounds with us. And Amber, I cannot wait to see yours. And Melissa is here with us this evening. Hello, my friend. Happy to see you again this week. I'm happy to see you. I lost my notes from last week about my 2 failed FETs. What should I be asking my doctor to do before my next FET, taking a few months off to reset, which I think makes a lot of sense, Melissa. People do ask all the time, do I need to be taking time off? Can I go from one embryo transfer to the next if they are not successful? And the answer is yes, you can. Medically speaking, you can. But you know what? Sometimes emotionally speaking, it's just too much to do that you do need to kind of take a little break. Both emotionally and financially, and just from the sense of kind of try to find your way. It's nice, really, in that regard, to take a little bit of a break. So there are some things that I would look at after a couple of unsuccessful embryo transfers. So first question is, well, all right, were you transferring blasts or were you transferring day 3 embryos? Because there are some clinics, particularly where I used to work, that do a lot of day 3 transfers. And the thing about a day 3 transfer is that you just don't know if that embryo would have survived anyway. If it's a normal embryo, then whether you transfer it on day 2 or day 3 or day 5 or whatever, it's going to grow in all probability. If it's not a normal embryo, then it doesn't really matter when you transfer it, it's probably not going to grow, and you're not going to get a another, you're not going to get a positive pregnancy test from that. Now, Melissa's embryos, Melissa tells me that these were blasts. So we know if it has grown to blast, then it has a higher probability of being able to get you pregnant. So if you had 2 unsuccessful blast transfers, you were able to make the blasts, which says something affirmative about your eggs. I would want to know, first of all, is the uterine cavity normal? So hysteroscopy or a saline sonogram. You do not need an HSG. You do not need the dye test. You just need to evaluate the uterine cavity to know that there's not polyps or fibroids or scar tissue or something else on the inside that's going to prevent that pregnancy from implanting. The second thing I would consider is, well, what kind of cycle are you doing? In most places do medicated or programmed embryo transfer cycles where we're giving you all the hormone, but it may be that using a different type of cycle, using the other one, whichever one you weren't using, might prove to be beneficial to you. And then I start thinking about, well, have you been evaluated for endometriosis? So even after a couple of transfers of untested blasts, I still then want to know about endometriosis. And that's the non-invasive test called Receptiva. Receptiva. And the website is receptivadx.com. And that looks to see if endometriosis is trying to stand in the way of your embryos being able to implant. And I think that would be a very worthwhile test. But then I start thinking about the immune system. I wonder if your ANA is positive. If it is, I think about a medication called Plaquenil. Certainly after a couple of unsuccessful transfers, I would want to have you on tacrolimus, also known as Prograf. So these are the sort of things that I think of there, Melissa, and hopefully that proves beneficial and you're able to jot them down. Talk to your doc about that. And, that begs another question. People ask, well, is it okay for me to ask my doctor about some of these things that I see on your show? And the answer is, of course, it's okay. Now, it's a different story if you go barging in and you say, well, I heard this and I want to know why you didn't do it. Well, what do you expect to have happen? People are going to, end up getting kind of defensive about that. Nobody likes, that kind of approach. But yeah, I think it's now, different docs have different levels of comfort doing things differently because some are very set in their ways and don't want to do things any differently because they believe that their way is the best way and there is no other way around that. But then again, if that's the case, then they owe you that explanation. Let them explain to you why that is. The days of the doc saying, well, I'm the doctor and that is the reason why. Those days are over, and that should never be the answer. That it is it's a collaborative process between doctor and patient, So my 2 cents there on that. Hey, guess what time it is? Time for the fuzzies with Fink. It's 5:30. This is a very special group of people. And I think that there is probably not a one of you out there who wouldn't go out of their way to help really anybody else, but especially other people maybe who are on the broadcast here. If people needed your help, I'll bet you would do that. And I think that my program probably selects out some of those nicer people. At least I'd like to think that's the case. So this is the chance for us all to get together, to sit here, kind of one-on-one with each other, and send out some positive vibes into the universe for each other. This fertility business is tough to go through. It is a crappy roller coaster. That's what I always say. The ups and downs, the emotional ins and outs are really just no fun to deal with. And it's supposed to be easier. It really is. But it's not just fertility. It's things like relationships. It's things like family. It's things like, tough business happening at work. All these things can get us down. And to know that there's someone else out there who cares is really enough to make a huge difference. So I want each of you to know that I care. And I want each of you to know that there's probably a lot of people on this list who also care about you. You are not alone going through this process. And that's for Glimpses of Jess. That's for Melissa. That's for Amber. That is for Mama Fran. That's for Sheila. That is for Rebecca Maynard. That's for Tiana. Oh, hi, Tiana. Nice to see you. Mrs. Tyler, Tor Jensen, Sharmilla for you, Kowser, Purple Butterflies, Lamu Hair, Ocean, Noodles for Life, Angela Sack, Rosa, Alexis, Tracy down in Miami. Hi there, Rosa. Janine Zaneda in Miami. Savannah, Blaxican Beauty, my friend. Angela, we said that. We've got, I think I got pretty much everybody's names. Oh, there was Marie, Jazzy Poo, if you're still here. Victoria Lynn, Marlena. Did I get them all? Megan, Vic, Daisy. Oh, yeah, here we go. Indipino Journey. Okay, I think I got everybody. DH7535. All of you folks, let's stand together as one, as a community together, and send out these good vibes right now to each other, from each other. And this is how we make the world a better place. You are not alone, my friends. This group of people is here to support you no matter what. And that, friends, is the 5:30 Fuzzies with Fink. Thanks for being a part of that. Please ask your friends to join me, even if it's in the 5-minute, from 5:25 to 5:35, so that we can get that. The more people that we have that are a part of that exercise, I think the better our universe really has a chance to be. And that is to each and every one of you. So thank you for being there for that. Okay, let's see what we got here. Tor Jensen says, I'm curious about your recommendations for an FET. That's frozen embryo transfer protocol after a myomectomy with recurrent implantation failure. So, what I typically do for recurrent implantation failure is I like to do a bunch of suppression. So first of all, after the implantation failure, I'd want to know for sure that you don't have endometriosis. And I think that Receptiva test is a really important thing to do. So if it's positive, then you suppress for 8 weeks on either Lupron or Alyssa or Myfembree. If you've tested and it's negative, then what I like to do is I like to really completely suppress your hormones. I like to give you daily dose Lupron, some birth control with daily dose Lupron, some overlap there, and then we start on some estrogen and progesterone. I really want to make sure that all those hormones are shut down so that I can control them completely and that there is nothing left to chance, right? That there's no variable there that I can't control. And then for sure, I would use tacrolimus or Prograf, which is probably the best studied drug specifically for recurrent implantation failure. I'd want to know for sure that you haven't been through, that you have had a recurrent pregnancy loss panel so that we can make sure that there's nothing else kind of in your blood that's trying to stop your pregnancy from implanting. That's how I would do your medicated cycle. I'd also want to know about your ANA, your anti-nuclear antibody, because that tells me really whether you need some Plaquenil, but that's how I like to do it. Now, there are some caveats to that, and that may be there are some people who have done these, programmed or medicated cycles again and again and again and don't get pregnant. And that might be the opportunity to say, well, maybe we want to try to switch that to a natural or to a modified natural type protocol. But Ms. Jensen, that's kind of the way, I start to approach it. Really, if you haven't really been fully suppressed in the treatment cycle, we like to use Lupron here in addition to some estrogen, progesterone, just to make sure that we are controlling every variable and nothing is left to chance. But for sure, tacrolimus, possibly Plaquenil, for sure a baby aspirin, because that one's easy. There are 6 supplements that I would for sure want you to be on, and that is the evidence-based protocol for what can a handful of vitamins do to get us pregnant. And the evidence for embryo transfer say prenatal vitamin, vitamin D, vitamin E, CoQ10, DHA or fish oil, and lastly, something called L-arginine, which increases your blood flow to the uterine lining. I would want to for sure make sure that you are on all those things. Kauser says, can you please tell laparoscopy or hysteroscopy tests for checking endometriosis? What's the purpose of these tests and when should they be done? Okay, so a hysteroscopy is to look inside the uterine cavity to make sure that there is nothing that we would call a filling defect. And that means a polyp, a fibroid, a band of muscle, a ball of muscle, some scar tissue, something that may prevent your beautiful, perfect embryo from implanting. That's a little camera that goes through the cervix inside the uterine cavity. That can be done in the office. It does not require anesthesia. It's usually a 15-20 second procedure. Now, if there's something on the inside that needs to be treated, usually we do that with anesthesia, but that's what a hysteroscopy is. The laparoscopy is a surgery that's done under general anesthesia where a little camera is placed through your belly button into the abdominal cavity so that we can look around and see if we can find endometriosis, and if so, to treat it. In the olden days, that laparoscopy was considered a basic part of every fertility evaluation. Nowadays, we know that really you don't need to have a laparoscopy unless it is potentially for other reasons. Now, looking with laparoscopy is still not a bad thing to be able to see if you have endometriosis. But here's my problem with that. Well, on the one hand, if you have endometriosis, okay, what are we going to do? Well, ideally, we excise it. But whatever endometriosis you see is always the tip of the iceberg. There is always going to be more of it that you cannot see. And so my recommendation when we find endometriosis is that we treat you medically anyway. Given that there is a non-invasive way to diagnose endometriosis, and that's through an endometrial biopsy, and that's the Receptiva test, that's the one I recommend because I kind of feel like, well, we're going to treat you medically anyway. Why do you need to go through surgery in order to get yourself there, especially when surgery has risk. General anesthesia is very safe, but it still has risk. And insurance, kind of being what it is, even though that may be covered, that surgery may be covered by your insurance, it may still take you, hundreds and hundreds, or maybe even thousands of dollars between deductible and copay, and everybody, kind of wants their piece. The anesthesiologist charges you, the doctor charges you, the surgery center charges you, on and on. It may just be cheaper to do the self-pay receptiva test anyway. But the indication is, when things aren't working the way they're supposed to, or my feeling is that, well, if you clinically sound like you have endometriosis, which is your periods are very painful, you have pain with sexual intercourse, and the other question is, do you have pain with the bowel movement? Those are kind of the three cardinal signs of endometriosis. Then if you want it for diagnostic purposes, I think it's not an unreasonable thing to do. That's how we look for endometriosis. Now, hysteroscopy can look for something called endometritis, which is a chronic inflammation in the lining of the uterus, but not the same thing as endometriosis. They sound the same: endometritis, endometriosis, but endometriosis is when that lining of your uterus that normally sloughs off when you have your period instead works its way up and implants in sites in your abdomen. So that's kind of the way I approach laparoscopy and how to diagnose endometriosis. Now, everybody has different opinions on that, and I will say your doctor may feel very differently, but my mind isn't so much changed by that, because there are some people who just love doing laparoscopy. Some docs just absolutely love it. And my feeling is, yeah, hey, it's fun, but if you don't need it, don't do it. Why do you need to have surgery? Why do you want to have surgery if you don't really need the surgery? And when you can make that diagnosis non-invasively and you're still going to treat it in the same way, to me, that's a better thing. Now, the argument there is that, well, if you've got all those symptoms and you live, your periods are a horror show because of pain and so forth, then there's some benefit to you doing the laparoscopy, because you're going to live a better life, because you can treat it, at least some of it, surgically, and it will make you feel better. So it's kind of the way I approach it. Hi to Carrie, who is on, I think that says Facebook there. Nice to see you this evening. Thanks for being here. Let's see what else we got going on here. We've got Katie. Hey, Katie, good to see you. And what else? What are your thoughts on using the expensive Omnitrope to potentially help with egg quality? For my last two retrievals before transferring. I'm 41. My AMH is 0.15. My antral follicle count is 6, but I'm only getting 2 to 4 mature follicles. So I will tell you, there is a lot of, there is some controversy really over Omnitrope. Strictly speaking, if you look at the data says that Omnitrope doesn't help. Omnitrope is human growth hormone, and yeah, it's expensive. The data says all it does is add cost. However, most of us have experience and say, well, gosh, our experience really says otherwise, that there are people who use Omnitrope who really get a measurable difference in egg quality. So for that reason, I do use it. I use it for folks who I believe are going to have a difficult time with egg quality, and that's certainly going to be those who are over 40 or those with a lower AMH. And for those who have had retrievals before and have had issues with egg quality. I think it can't hurt. It's not going to harm anything except for potentially your wallet, right? Because it is expensive. But if you can do it and your doctor feels good about it, then I think it's a good thing. So yeah, there are some studies that show it doesn't make any difference, and there are other studies that show it does. In my experience, it can. And so here's the problem. We just don't know exactly in whom it's going to make a difference. So it makes a difference in some people, I think. but in some people it wouldn't. And exactly who are those people? Well, we really just can't say because it doesn't, it's hard to study that sort of thing really all that granularly. But I would say if you have the ability to do it, if you can find a way to make it affordable, I think that there is no harm in using it for the short term. So I would. Ms. C.R. Tyler, I think that says, what are your thoughts on the new study showing benefits for using rapamycin for egg retrievals? Yeah, there is some evidence out there that says using a prescription medication called rapamycin, can have some benefit on egg quality in some people. And while the study itself was not a huge one, and it's very hard to know if these things are generalizable to the public at large. Or were there findings that it did improve egg quality specific to, some certain cohort that they were looking at in the study? That's why it's really hard to study these things, these kinds of IVF type outcomes. But I think there really is potentially a lot of promise to it. I don't know that it's ready for prime time. In other words, I'm not sure that this is not a change that we are starting to, make based on a study that came out not that long ago. Put it this way, it hasn't altered the standard of care, but it may at some point. And if it's something that can help egg quality, then hey, I'm all for it, because that is really an everyday challenge in IVF. Good question there. Sharmila asks, does the Thorn prenatal should it be taken 3 tablets a day? The bottle says it, and it's the same for postpartum as well. Yeah, I think the Thorn prenatal is a really good one. So you may know what I say about prenatal. Don't go crazy on prenatal vitamins. There are these, $80, $100, $120 prenatal vitamins that you see on the internet. And you say, well, it's so expensive. It must be good. It must make a difference because look at what it costs. And I say, well, unless they can promise you that your child is going to be a United States senator as a result of using this expensive vitamin, don't overspend on a vitamin. Most of it ends up in your urine anyway. But Sharmila, especially because you're breastfeeding, and you do have a beautiful baby, by the way, I would say, the Thorn prenatal is a good one. It's very reputable. It's well tolerated. And yeah, I say stay on your prenatal as long as you're breastfeeding, and really, if you can, for at least 6 weeks after you stop. Prenatal is a really good vitamin. There's no harm to just kind of staying on it in general. People who do stay on their prenatals will find that their hair is shinier, it grows better, their skin often looks better, their nails definitely grow faster and are stronger. So for what that's worth. Rosa says, wanted to say, oh, thank you. My baby is here. Thanks for guiding me through my endometriosis and your protocol and all your help. Rosa, I can't wait to see your baby. Please send me a picture of your baby. This has been a long time coming. Rosa has been through a lot. And I don't want to tell too much of your story here for privacy, Rosa, but Rosa's a little older, had IVF, had endometriosis and an endometrioma in a pregnancy that was originally a breech baby and then flipped around. And I'm curious to know if you had a vaginal delivery. And our thoughts are with you here. Congratulations, Rosa, and thank you for your kind words there. Carrie says, if I do IUI with known PCOS, if I have undiagnosed endometriosis, would IUI still work? Well, so here's the thing. Yeah, there's no reason that you can't do an IUI. And really, endometriosis is a very common thing that is commonly silent. So we ask about these symptoms, about your pain and pain with periods and pain with sex and pain with the bowel movement. And that's the most common clinical presentation. But as you may have heard me say before, that's the classic presentation. But the most common presentation is silent endometriosis, that we just don't know that you have it. Now, endometriosis does not always prevent people from getting pregnant. Um, because there are a lot of folks with endometriosis who get pregnant and they do just fine. So I don't want you to think that the mere presence of endometriosis means, oh, pull the plug, it's not going to work. You will not get pregnant. I would say absolutely, if IUI is the right choice for you, do that IUI until you see it doesn't work. And then you kind of start to try to figure out why not. What we know about that endometriosis is that it affects the way we transfer embryos in IVF, but it doesn't say anything about whether its presence is affected, how that may affect the lining in people who are not doing embryo transfers, but who are just trying to get pregnant on their own. Yeah, if that's the right choice for you, absolutely do that. And I say, don't give endometriosis another thought. You may have also heard me say before that I've gone in to do let's say a tubal ligation, a tubal sterilization on someone who maybe she's 44, she's had 5 kids, no problems with pregnancy whatsoever, and just wants to know that she doesn't have to worry about pregnancy anymore. And we put the camera in, and lo and behold, she is covered in endometriosis. And we're like, oh my heavens, how does she not have any symptoms from this whatsoever? Well, she clearly didn't have any problem getting pregnant all those times, and she doesn't have pain with her period. So, it's not a black and white thing, this endometriosis. It's not binary, as we might say. It's not a 1-to-1 ratio that if it's there, it's going to cause pain and it's going to cause problems with pregnancy. So it can be there. It can look really terrible and cause you no symptoms at all. So I would say proceed, my friend, do your thing and get yourself pregnant. What do you think of that plan? Let's see what else we got going on here. We've got a few more minutes. Do you see, this comes from Angela, do you see pregnancy with a bicornuate or septum uterus successfully? And the answer is yes, absolutely. You do. A bicornuate uterus is a uterus that kind of looks like a heart. It has 2 cornua. So here's the cervix, and basically there's what we call a horn over here and a horn over here. That's called a bicornuate uterus. It's just sort of shaped like that. Now, that can be associated with some issues with like preterm labor, or certainly also malpresentation, that your baby may be more likely a breech baby. But that uterus, that shape of the uterus, you really can't really do anything about, because you were born with that. And that's just the shape of your uterus. It's called a Mullerian anomaly, and you're quite literally born with that. A septum is a muscular band that goes down the middle of an otherwise normal uterus. And so I can't really draw it here, but the septum would be going like that. And the septum can cause you problems because it's taking up a bunch of space that the endometrium would otherwise be using to try to implant a pregnancy. So there has been some association with recurrent miscarriage and pregnancy loss. There's some recent data that says that, all septums do not cause that problem. And so it used to be that if we identified that you had a septum, we would tell you that you have to fix that septum before you get pregnant. And the surgery for it in the right hands, it's very easy for us to do, to be able to just kind of use a little pair of scissors and go chip, 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 and take the septum, that muscular band, down so that the uterus itself becomes normal. We used to tell you, oh, you got a septum. Yep, we have to treat that because it's going to cause you to have a miscarriage. But the newer data says it doesn't necessarily. That it's a conversation that's worth having, but many people will get pregnant with that septum in place anyway, and that we don't necessarily have to treat it. But the question is, well, all right, how much do you want to risk having miscarriages and stuff, only to then go back and say, okay, well, now we need to treat that septum, you know? That's kind of where we are with the septum. But yes, absolutely, pregnancies happen with both septums, and certainly a bicornuate uterus, because that is just a normal kind of variant. Let's see. Can you take tacrolimus and Plaquenil at the same time? No, you cannot. Angela, are you a pharmacist? That's an excellent question. No. What I find in folks who have a positive ANA, I like to treat them with Plaquenil, because Plaquenil can actually, which is a drug called hydroxychloroquine, can actually reverse that positive ANA. And it's really just it's a kind of a generic, non-specific marker of inflammation in your body, but Plaquenil can make that negative. The tacrolimus or Prograf is used closer to the time of implantation for recurrent implantation failure, where it helps to block the immune response that may be causing your body to reject the pregnancy. But those usually stop the Plaquenil, and then you start the tacrolimus. You don't take those together because those have a theoretical risk of prolonging what's called your QT interval, which is, you know, the way your heart beats. And so we don't want to do that. But Angela, good question. Strong work there, friend. Strong work. My friend Blaxican Beauty. Hello, friend. I found out Friday that I have a blighted ovum. Oh, no. Oh, gosh. And I go into for my DNC tomorrow. I was wondering what your thoughts are on doing an IUI after going through something like this. Well, first of all, I'm so sorry, my friend, to hear that you are going through this. It's truly just not a fair thing to be able to get that positive pregnancy test, only to then find out that then something has gone wrong and the pregnancy has stopped growing. So I am very, very sorry to hear that. The blighted ovum is, you know, really as a result of an egg issue. It means that, you know, you created a pregnancy that basically had a placenta, but it didn't have an embryo on the inside. So it's also what's known as an anembryonic pregnancy. There is, you know, you can certainly do an IUI, but the success rate of IUI starts to drop off very dramatically over the age of about 38. And certainly in our 40s, in most cases, an IUI is no more effective at getting you pregnant than would be home intercourse. So is it worth doing under that circumstance? You know, I don't remember exactly how old you are. You've told me before, and I apologize, but I think you're in your 40s. And I would say, well, you know, it kind of depends on why you've gone to IVF to begin with. It should be the fastest path to pregnancy, but over 40, IUI just doesn't have great outcomes. And so it's very hard for me to tell people that that's a great idea, especially when you have both a financial and really an emotional investment into it. It's just really hard to have, you know, another procedure, another month go by trying to get pregnant when it doesn't work. So, gosh, our thoughts really go out to you tonight, and I'm so sorry you had to go through with that. The DNC will be over before you know it, and as I always say, happier times ahead for sure. Angela says, I thought the Receptiva test wasn't really accurate. No, it's pretty accurate. Yeah, it's considered to be a pretty good test. So I do recommend it. Okay, folks, looks like we are going to be out of time for tonight. I really appreciate you all being here with me. Again, my favorite place to be week after week. So thanks so much for being here and for joining for the 5:30 Fuzzies with Fink. Please be here next week for that same thing so we can send out those good vibes into the universe. Hey, this pregnancy business is not the book of your life. This fertility thing is just a chapter. And what are we here to do? We are here to rewrite it together. So until next week, every step forward with love, every step forward with kindness to other people. Not enough kindness in the world. But most importantly, every step forward with hope. Because tomorrow is a new day full of all new adventures. From Pensacola, I'm Dr. Randy Fink. Thanks for being here.